Welcome, everyone. Thank you for joining us for today's podcast. My name is Emilio Madrigal, and I am joined by some of my co-residents, Rifat Manan and Wei Zhang, and we are in Manhattan, New York. Today's podcast is titled Benign Mimics in the Urinary Bladder and Prostate Gland, and will be presented by Dr. Sean Williamson, who is currently in Detroit, Michigan. Dr. Williamson is a senior staff pathologist at the Henry Ford Health System and a clinical assistant professor of pathology at Wayne State University School of Medicine. He recently published an article in the American Journal of Surgical Pathology titled Renal Cell Carcinoma with Chromosome 6p Amplification, including the TFEB gene. And we are very excited to have him join us today. Just a little housekeeping before we get started. If you have any questions during the session, please type them in the Facebook or YouTube chat boxes. Rafat and I will bring them up at the end of the podcast. Now, without further ado, we will turn the time over to Dr. Williamson.
Thanks very much to both of you for the opportunity to speak in this format. As I'm sure many of you know from interacting with me via social media, you probably know that I'm a big believer in the social media movement for pathology. So it's a great honor to have the opportunity to speak today in this exciting new format. I have no conflicts of interest related to this presentation, and so I guess I'll go ahead and get started. And so just to start out with the sort of importance of benign mimics in the prostate gland and the urinary bladder, urologic specimens are kind of interesting in that the rate of cancer diagnosis is pretty high. With the transurethral resection of bladder tumors, for example, the diagnosis of cancer is almost presumed, and when there's a benign diagnosis, it sometimes can be a surprise. And then with prostate biopsies, the rate of cancer diagnosis is fairly high as well, since patients are already flagged as having a high PSA or some other clinical findings to raise concern for prostate cancer. And so awareness of the benign mimics is important to keep in mind as we are sort of accustomed to making diagnoses of cancer in urologic specimens. And so the first part of my talk is on the prostate gland, and I apologize that sort of 3/4 of it is probably prostate. Maybe that's because prostate cancer is deceptively bland looking. There are more things to consider when you're making a diagnosis of prostate cancer, but about the last 1/4 is about the bladder. And so in order to fully utilize the social media online format, I inserted a couple of QR codes here if you'd like to get some full text articles. This is a nice article in Modern Pathology, and although it's from 2004, which is more than 10 years old now, actually a lot of the content is relatively up to date, even though it's more than 10 years old. Dr. Shrigley wrote this review as part of the long course from that year, and it's a very nice review on benign mimics in prostate. And then another nice review from Drs. Hamid and Humphrey addresses the prostate and the bladder, much like I'm going to do here, and that's also free, full text available in the Archives of Pathology and Lab Medicine. So to start out with the topics about the prostate, one of probably the most common lesions that you might entertain a diagnosis of prostate cancer is partial atrophy, and that's because this is a small round gland lesion that might raise a consideration of a low-grade prostate cancer. This is sort of referred to as partial atrophy because the glands have loss of some of the cytoplasm like usual atrophy, but they don't have that completely dark appearance with angulated contours like fully atrophic glands do. And so they can be kind of confusing for that reason. And so here's a full screen example of one of these. You can see the glands are small and round. At least some of them have a hint that the epithelium is sort of monolayered, although probably a few of them you can appreciate probable basal cells at least. Here's another example. And one tip that was pointed out to me by one of my mentors, Dr. David Grigno at Indiana University, is that you often can see that the cytoplasm is not very tall. So if you can see the arrow here, the nucleus, these two nuclei are almost the full height of the cytoplasm, but then the cytoplasm swings out quite a length laterally before you see the next nucleus. So if the cytoplasm is not very much taller than the nucleus, but a lot wider, that's often a helpful clue to the diagnosis of partial atrophy. Here's another area, and another tip that Dr. Grigno always pointed out to me is that some of the nuclei are very small, dark, and pinched, like you can see here, almost like you squeezed it between your fingers and made it into a little a little raisin or something like that. Here's another higher magnification. I think it illustrates that phenomenon of the large amount of lateral cytoplasm, but not much apical cytoplasm. And this one might raise your concern for prostate cancer because you can even make out some small nucleoli in this particular lesion. Here's one that I think was challenging because the cytoplasm of these glands is fairly dark. So dark cytoplasm is a feature of prostate cancer. And classically, partial atrophy has very pale or light cytoplasm, although this one or two down at the bottom do seem to have that lateral cytoplasmic accentuation we were talking about. And so looking at immunohistochemical staining on this particular one, this is a PIN4 cocktail. So it's a dual color with AMACR or racemase and basal cell markers P63, CK5, and 14. And you can see, interestingly, that some of the glands seem to have a basal cell, like that one seems to have one. This one seems to have several. The two down here may not have any at all. But this brings me to, I think, is one of the most important points about benign mimics in the prostate gland, is that if you're looking at some glands, some of them look like they have basal cells. Some of them don't necessarily have basal cells that you can appreciate. If they all have very similar cytology, that is, you can't make out a stark difference between them, then in general, I would interpret that lesion as a whole as benign. Or if you remain uncomfortable with it, it's at least not diagnostic of cancer. At most, I would consider that an atypical proliferation. So you could use the term atypical glands or atypical small acinar proliferation. But whenever you can't make out a stark difference in the cytology between those glands that do have basal cells and those that don't, I would hold back and perhaps even interpret the lesion as a whole as benign. Another similar lesion is atypical adenomatous hyperplasia or adenosis, or at least that same principle of the partial basal cells holds true. So this is a transition zone lesion. Typically, it's part of a hyperplastic nodule, and you can see what looks like a normal BPH nodule, but then at the edge, the glands get smaller, round, and crowded. Some authors would prefer to use the term adenosis for this lesion, and the advantage of that is that it doesn't have the word atypical in the name, and so it wouldn't potentially confuse anyone with atypical glands or atypical small acinar proliferation, that any kind of biopsy or surveillance is needed for this lesion. Some of the cancers that were in the past considered Gleason score 5 or less, so scores of less than 6, may have actually been this entity, atypical adenomatous hyperplasia, AAH, or adenosis. Now, of course, with modern immunohistochemistry, we can show that they have a patchy basal cell layer, and in fact, they're not cancerous at all. So that may contribute somewhat to the fact that Gleason scores of less than 6 are essentially not used, or now using the modern Gleason grading, grade group 1, less than 6, are very rare in current practice. So here's an example of something that I think qualifies for AAH in a needle biopsy. You can see that there are some glands that are big, complex shaped. They have corpora amylacia or concretions in them. So those are all benign features. But then as we zoom in, there are some glands that are crowded, small, and round. But I think this one also illustrates that there's really no cytologic difference between the ones that are small and crowded and round and the ones that are big and tufted and branched. And so if you were concerned about the small crowded appearance in this particular case, you can see here again, this is a 2-antibody cocktail. So it's got only a single color brown, but the nuclear brown staining is P63, and the cytoplasmic brown staining is racemase or amicar. And so you can see that, again, many of the glands have a basal cell with P63. Some of them don't. So these 3 or 4 down here at the bottom seem like they don't. But again, and this one here in the middle seems like it doesn't. But again, not much difference in the racemase staining between those that do and do not have basal cells, and the cytology is essentially identical. So I would feel comfortable considering this totally benign in this particular case, interpreting the whole lesion as AAH and therefore not being worried about cancer. Here's another example of AAH or adenosis where you can see the architecture better. This is from a resection specimen, so you can see the whole nodule better. And in this one, you can see that there's a circumscribed nodule. Some of the glands are big and branched and tufted, so they're morphologically obviously benign. But then at the edge of the nodule, there's a lot of small round glands. But again, we zoom in, not much of any appreciable cytologic difference between those that are benign looking based on their architecture and those that are small and round. Here's an example of the 4 antibody dual color staining in a case like this from a larger resection specimen. You can see that all the big branching glands have a nice robust basal cell layer, and then as we get over here into the small round glands at the edge, they start to have a less prominent basal cell layer. But if we zoom in, hopefully you can see on the image that at least some of them do. So I think here are some basal cells. The color differences are not as impressive in the photograph, but hopefully you can make out that there are some basal cells here. And so again, I would interpret this whole lesion as benign based on the fact that at least a subset of the glands that all look the same as each other do have some basal cells. Here's a high molecular weight keratin staining in the same case. And interestingly, in this particular field, you can see that only really 2 glands have a nice obvious basal cells, and the rest of them seem that they don't. But again, cytologically, they all look very similar to one another, and so I wouldn't let that bother me. So you might wonder about this lesion. Is it a precursor to cancer? It's got a number of features that are similar to cancer. It's got small crowded glands. You can have some positivity for racemase, as we saw in the last one, that could raise concern about cancer. You can have crystalloids in the lumen, which is a cancer feature, and the basal cells seem to be partially lost. However, some of the features against, of course, there are some basal cells. This lesion has been shown to lack TMPRSS2 ERG gene rearrangement. If you're familiar with it, the ERG gene rearrangement has been reported in about 40 or 50% of prostate cancers, and it's very specific for prostate cancer. However, in transition zone cancers, this is less commonly present, and so it may not be the best test in this circumstance. But at any rate, there's currently no evidence that this is a precursor lesion, and so there's no recommendation that you necessarily need to do anything in terms of repeat biopsies or follow-up for a patient who has only AAH. Sclerosing adenosis is another lesion that's very similar to AAH, especially in the combination of small round glands with bigger, more benign appearing glands, although it has one major difference. And are any of you that are on the call, does that major difference jump out at anyone?
I'm not sure. Is that stromal sclerosis or stromal fibrosis?
That's true. So I guess I should have said there's maybe 2 major differences. So one is certainly that the stroma is different. So the stroma is more cellular, it has more of a cellular stroma, and so the glands become kind of crushed and compacted between the stroma, and we'll see some good examples of that in a minute. And the thing that I was fishing for is that actually the basal cell layer has myoepithelial differentiation. And so for those that do breast pathology, sometimes it's easy to switch back and forth between the term basal cell and myoepithelial cell. But in the prostate, the basal cells actually are not myoepithelial cells in the majority of benign prostatic tissue. Only in the lesion sclerosing adenosis, they, for some reason, take on myoepithelial properties. And so they are positive for basal cell basal cell markers like high molecular weight keratin and P63, but they have the additional feature of being positive for myoepithelial markers like actin and S100. And so here's an example of one of these that's sort of scary because the small glands are so crushed and compacted in between the cellular stroma, they almost look like high-grade cancer, actually. So this could potentially even mimic a Gleason pattern 4 or pattern 5 cancer as compared to the other things we've talked about so far, which generally would mimic a 3+3 or a grade group 1 cancer. Here's again some areas where the glands almost look like poorly formed, not really great lumens, just cords of cells. But again, using immunohistochemistry, they still do have a nice basal layer as demonstrated by the PIN4 cocktail stain. Here you can see the bigger branching ones have a really nice basal layer. And then in the mess of the sclerotic stroma, you can see that there's a bunch of basal cells. It's hard to make out the glands themselves, but there's at least a mess of basal cells in there. And here's another field showing that S100 positivity of the basal cell layer, which is unique to sclerosing adenosis. Here's another example, very cellular stroma. And again, some of these glands, I think you could be worried that they are a higher grade cancer, either pattern 4 or pattern 5, because you can't really see the lumens very well. So another type of adenosis, a rare lesion that was reported from Dr. Epstein's group, Dr. Lotan and Epstein, is what the authors termed diffuse adenosis of the peripheral zone, which is an interesting lesion. They encountered it in especially young patients to have a proliferation of non-lobular crowded glands, but similar to what we've talked about so far with AAH and sclerosing adenosis, this seems to still have some basal cell layer. Potentially, these patients seem to have a higher risk of eventually being diagnosed with cancer. Although this is probably quite a rare lesion, as just 1 or 2 days ago, I checked the PubMed literature search again, and I couldn't find any additional studies on this entity since the 2008 paper by Lotan and Epstein. So probably a rare lesion, but an interesting phenomenon. And sometimes I do notice that in young patients, the prostate glandular tissue has more crowded small glands. So something to keep in mind. It contrasts to the usual location of AAH and sclerosing adenosis, which are in the transition zone. This entity described by Lotan and Epstein occurs in the peripheral zone. So moving on to another entity, basal cell hyperplasia, which usually is pretty straightforward, but can sometimes mimic cancer. This is one of the histologic manifestations of nodular hyperplasia, but there are a few patterns that we'll talk about in a minute which can be sort of confusing or at least slightly deceptive. So here's a straightforward example of basal cell hyperplasia, and what we usually expect to see is that the basal cells kind of proliferate or heap up on themselves so that they fill up almost the whole lumen of the gland. So like this one in the upper center here, you can see that the gland is almost entirely filled with basal cells. In some of them here in kind of the mid-center, this one you can see that there's a lot of basal cells heaping up, and there's a tiny secretory layer that's kind of pushed toward the middle. So this would be a fairly typical example of basal cell hyperplasia. Another clue that you're in a hyperplastic nodule is that you also have these vessels with a little bit of hyalinization around them. And so even if you have a stromal predominant nodule of hyperplasia, so no glands whatsoever, but just stroma, if you see these vessels, that can be a helpful clue that that's what you're dealing with. Here's another example where you can see more usual glands at the right-hand side of the screen, and then glands at the left that have some degree of basal cell hyperplasia, so they just look more cellular and blue. But here's an example of one that I think could be more worrisome or more deceptive, where the glands take on essentially a cribriform appearance. So at the right, you can see fairly normal hyperplastic glands, and then at the left, you can see that they start to become sort of cribriform. And this area might be very worrisome if you saw it just by itself in a small biopsy, or if I just gave you one image of this alone. But if you look around, you can see that, for example, in this gland at the right, there's a heaping up of basal cells at one edge of the gland. But then on the opposite edge, it looks fairly normal. So you've got your pale secretory cell layer and just a few basal cells. And if you compare that heaping up at the one edge of the right to the rest that we just looked at with that marked heaping up of basal cell layers, you can appreciate that this whole thing is a nodule of basal cell hyperplasia. And I'll show you some immunohistochemistry with the next case that can help out if you're really confused. This is one that I think was exceptionally impressive as an example of deceptive basal cell hyperplasia, because the glands with basal cell hyperplasia really look like they're essentially infiltrating in between normal glands. So there's this stretch of small glands that are going in between glands that look pretty benign. And so I was very impressed with this case as a challenging mimic of prostate cancer. Zooming into higher magnification, they have even more deceptive features. You can see nucleoli in the cells of basal cell hyperplasia. If it's projecting well on your screen, you might even see that there's blue mucin over here. Even better here, shown at high magnification, blue mucin, prominent nucleoli. So for all intents and purposes, this one looks a lot like prostate cancer. But using immunohistochemistry, you can see that there is actually a robust layer of basal cells all throughout a lot of these glands. And an interesting thing about basal cell hyperplasia, even though morphologically it looks like the basal cells are heaping up on each other and filling up almost the entire lumen of the gland, by immunohistochemistry, the staining pattern does not always label every single cell that you think is a basal cell. So here there's a robust layer around all of the glands, but it doesn't fill up all the lumens like I would have guessed based on the morphology. You might, if you're keeping up on your rare entities in genitourinary pathology, you might say, well, hey, wait a minute. I've heard about this entity known as P63 positive prostate cancer. Could this be one of those? And I think the reason why this is different is that in the rare cancers that are positive for P63, the distribution of the P63 positive cells is not in a basal distribution. So here you can see that the nuclei that are staining for P63 are clearly at the base, and then the more luminal cells are negative. Whereas in P63 positive cancers, the glands generally have a monolayered appearance, just like regular cancer, but yet that monolayer of epithelium is P63 positive. And as another helpful feature, this is a high molecular weight keratin staining in the same case. In the P63 positive cancers, the high molecular weight keratin is usually negative, so you can use that as your ancillary support that you're dealing with a true P63 positive cancer. But in this case, being just a basal cell hyperplasia, the basal cells are again highlighted well with the high molecular weight keratin staining. So this one I think is an exceptionally tricky example of basal cell hyperplasia mimicking infiltrative cancer, but you can see this to a lesser extent as well. Something to keep in mind also is that sometimes you can have a really impressive nodular basal cell hyperplasia that makes almost a nodule in and of itself of pure basal cell hyperplasia. And it can have multiple cribriform lumens, just like adenoid cystic carcinoma of the salivary gland or other organs. And so the criteria that are used for distinguishing that from basal cell carcinoma of the prostate or adenoid cystic carcinoma of the prostate, which is essentially considered a form of basal cell carcinoma, are that the lesion is localized. So when you have basal cell hyperplasia with this pseudo-adenoid cystic appearance, it should be localized to the transition zone, so it should be a fairly circumscribed nodule and not infiltrative. It should not have perineural invasion or extraprostatic extension. And there's a nice reference from Dr. McKinney and colleagues that was published several years ago in American Journal of Surgical Pathology, which you can look to for a nice listing of criteria on how to distinguish these funny basal cell proliferations of the prostate from basal cell carcinoma of the prostate, which is very rare. Another uncommon manifestation of basal cell, nodular hyperplasia is the entity clear cell cribriform hyperplasia. So the thing that can be deceptive about this entity is that the glands are cribriform, so they have multiple punched out lumina. The cells are somewhat clear or pale staining at least. But again, the basal cell layer is intact, and this lacks marked nuclear atypia. So here's an example. Again, this should be in the transition zone, so usually part of a hyperplastic nodule. It's an exception to the rule that almost everything that's cribriform in the prostate is cancer. Clear cell cribriform hyperplasia. So here's higher magnification. You can see these glands that have a pretty impressive cribriform architecture. But then at least in some areas you can make out their basal cell layer, or if you need immunohistochemistry to prove that there's a basal cell layer. And distinguishing from intraductal spread of cancer is the fact that the nuclei are not very pleomorphic. Here you can see maybe teeny tiny nucleoli, but they don't have that marked nuclear atypia of an intraductal cancer. And the transition zone circumscribed location can also be helpful in this situation. Here's another area where you can see a pretty nice basal cell layer in clear cell cribriform hyperplasia of the prostate. Any questions so far from anybody that's on the call? Another entity that can sometimes be perhaps a clinical mimic of prostate cancer and maybe a microscopic mimic as well is what we call nonspecific granulomatous prostatitis. So sometimes these patients will have an abnormal digital rectal exam, a very impressive nodule on the digital rectal exam, or an elevated PSA. So it can be a clinical mimic of prostate cancer. And then if you look at the morphology, depending on what kind of a pattern you see, that might potentially be disconcerting microscopically as well. But this is called nonspecific because it's not known to be associated with any particular etiology. It's not the big necrotizing granulomas that you get with BCG therapy. You can't find any organisms when you have this kind of a pattern. And the hypothesis is that this results from some sort of duct obstruction and duct rupture, which causes an exuberant granulomatous reaction. So here's a higher magnification of a needle biopsy with nonspecific granulomatous prostatitis. Sometimes the appearance is essentially a spindle cell solid lesion, and it can be difficult to recognize that it's granulomatous. But here, for example, you can see a multinucleated histiocyte in the middle of the field. So if you were going to be misled, you might think that this is some kind of a strange high-grade prostate cancer, at least in pattern 405, or sarcomatoid cancer or something like that, although that's very rare in the prostate. But something to keep in mind is this entity of nonspecific granulomatous prostatitis. Prostatic infarct is an interesting phenomenon that you can see fairly commonly if you look for it in either TURP specimens or in partial prostatectomy specimens for BPH, so the simple prostatectomy where the surgeon enucleates the transition zone of the prostate. And so when you have this phenomenon, you have basically a nice zonation pattern that can help you to recognize it. So in the center of the lesion, there's necrosis, and then you go out from that and you see squamous metaplasia, and then you go out further from that and you see the glands turning back into normal prostate glands. And so the origin of this is not totally clear. It's probably due to some combination of BPH where the prostate is so big that it obstructs the vascular supply to certain areas, and possibly some component of the patient having pre-existing vascular disease. But this can cause a sudden rise in PSA, which can be worrisome for cancer. Although in contrast to prostate cancer, the PSA will spike very high, and then it can resolve very quickly, which would be strange for prostate cancer. So here's an example of this blown up to the full screen. You can see the zone of necrosis. And then in the edge of that zone, that you can see these funny glands with squamous metaplasia that kind of have an irregular or jagged contour. And so if you see that alone, you might think, is this some sort of urothelial carcinoma or squamous cell carcinoma invading the prostate? But if you keep in mind that zonation pattern and look for it, you can recognize that this is the phenomenon of prostatic infarct, which is not uncommon if you look for it in nodular hyperplasia specimens. Something else that can cause a small round gland lesion that can sort of mimic prostate cancer is the glands of the verumontanum, or the entity known as verumontanum mucosal gland hyperplasia. So the verumontanum is essentially a hump-like landmark that protrudes into the urethra. So this hump is kind of like an arrow pointing towards the anterior of the prostate. And often the glands in the verumontanum are small and round and very crowded. And when you have a lot of them, sometimes people use the term verumontanum mucosal gland hyperplasia, or VMGH. And so here's an example. This hump is protruding into the urethra. The anterior of the prostate is this way, posterior of the prostate is this way, and these are probably the ejaculatory ducts here emptying into the urethra on the left and the right. And when you go to higher magnification, you can see that this has very small, crowded, round glands. Often we don't see this lesion on needle biopsies because the needle biopsies are mostly targeted towards the left and right posterolateral peripheral zone. So the needle biopsies are mostly not aimed toward the midline of the prostate, but occasionally you can capture it in a needle biopsy. And something that can be helpful in recognizing that you're seeing verumontanum glands is that many of them often have these dark red concretions in them. So if you see a lot of these dark red concretions, that's a clue that you might be dealing with VMGH. Here's a higher magnification. Again, these will have a basal cell layer if you need to do immunohistochemistry to prove that. And again, the cytology is very bland. It doesn't have nuclear features of cancer. Here's an example in a transurethral resection of the prostate, and was a little bit challenging because we had just a thin strip of tissue here with a bunch of small crowded glands. But again, these dark red concretions in almost all the lumens was a helpful clue that this is probably just verumontanum glands in the transurethral resection of the prostate. Nephrogenic adenoma is a really interesting lesion. The residents here in my program will tell you that this is one of my favorite entities for some reason. I always quiz them on it. And a warning, I'm going to ask for input in a few seconds. Typically, this is associated with inflammation or irritation. The previous term was nephrogenic metaplasia, but actually now current thinking is that it's not metaplastic. And so does anybody who's on the line know what the current thinking is of where it comes from?
It is neoplastic.
Okay. Oh, sorry, what was that?
These are neoplastic, right?
So the current thinking, so we use the term adenoma to more reflect, what we think of it, that it's not exactly a metaplastic change of the urothelium. And so there was a really interesting study that was published in the New England Journal of Medicine. I have the reference here at the bottom of the slide in 2002. And in this study, what they did was they looked at patients who had a renal transplant that was the opposite gender of the patient. So like say the patient was a male and had a female kidney transplant from a female donor. And they looked at the sex chromosomes of the nephrogenic adenoma lesion, and it matched the kidney more than the patient. So there were cases with the XY nephrogenic adenoma in a female patient and so on. And so the current thinking is actually that you have renal tubular cells that actually flow down in the urine and they implant into a site of injury, almost like the seeds implanting into the soil. So I always quiz the residents here in my program on that. I think it's a really interesting and unique way that the current thinking is for the development of this lesion, nephrogenic adenoma. And so rather than considering it a metaplastic process, it's actually, that's the thinking of where it comes from now. So here's an example. You can see the urethral mucosa with urothelium and then a bunch of these small round glands. So if you're thinking about prostate cancer, you could be worried about this because it has a small round gland pattern. Although in general, the glands are usually more bland, flattened or cuboidal lining epithelium without the atypia of prostate cancer. So rarely nephrogenic adenomas will have prominent nucleoli, sometimes when there's associated inflammation, but usually they're much more bland than prostate cancer, so that can be one helpful clue. In this one, you can perhaps make out to some extent that there is a basement membrane layer around some of the glands, maybe this one, and I'll show some examples later that have even better basement membrane layer. And having this very flat attenuated epithelium would be strange, although probably not impossible for prostate cancer. Oh, actually, here at the right-hand side, that's probably an even better example of a basement membrane layer over here. You're going to higher magnification. Some of the glands will even look poorly formed, where here you have just one nucleus or maybe two nuclei and then an eccentric ring of cytoplasm. This is another one where there's a little bit of crush or cautery artifact, and so some of them are more blue looking, and so this particular area you might be more concerned that you're dealing with a prostate cancer, although over here the epithelium is has a hobnail appearance, which would be perhaps a clue that you're dealing with nephrogenic adenoma. And so if you use your usual prostate cancer stains like racemase and P63, you might be misled since these will not have a basal cell layer with P63. So in this particular example, this is the PIN2 cocktail stain. The cytoplasmic brown staining shows that they have a decent amount of racemase positivity, which is similar actually to the renal tubules. You often have a pretty strong racemase staining in renal tubular epithelium, and they have no P63 positive layer. Here we are zoomed in, even higher magnification. So this is essentially a prostate cancer-like staining pattern using P63 and racemase. But the helpful clue is that they'll be positive for PAX8, which is a renal-specific epithelial, or fairly renal-specific epithelial marker. Luckily, PAX8 is generally negative in essentially all of the prostate cancers that have been studied so far. Here's another example in a needle biopsy that I thought was sort of tricky. You have the needle biopsy going along here. There's some epithelium. Perhaps a clue that you're looking at something in a periurethral location here is that the biopsy kind of goes and then it hits this flat epithelium and there's no more tissue beyond that. So maybe that's a clue that we've punched the biopsy into near the urethral mucosa somewhere. And you have this very crowded proliferation of round glands that might make you worried about prostate cancer. There's even probably some blue mucin right here. But in this particular case, the tissue is starting to cut away a little bit, but you can see the PAX8 positivity of the glandular epithelium. Interestingly, looks like the urethral mucosa is also PAX8 positive in this particular case as well, which is an odd thing, but that I've encountered occasionally. So some tips for nephrogenic adenoma. Usually it's in a suburethral location, and the depth that it goes down is very limited. So it goes down to a short depth under the surface epithelium, and then it stops. So unlike prostate cancer, it's not going to be located deep within the prostate adjacent to benign glands. It's usually located right next to the urethra. If you see the thick basement membrane layer, that can help. The PAX8 positivity can help. But if you use other markers like Amicar, P63, high molecular weight keratin, or GATA3, you can have mixed results. Some of these will be high molecular weight keratin positive, and you can have some positivity for GATA3. I wonder if that has something to do with which renal tubular epithelial cells that the lesion originated from. So if it's, say, a proximal epithelium, then it'll be racemase positive, but high molecular weight and GATA3 negative, and so forth, versus more a distal epithelium. Interestingly, a nice study from Rohit Mehra's group at University of Michigan talked about using the PIN4 stain in this context. So the PIN4 stain, as I mentioned earlier, you could be misled by the absence of basal cells with P63 and the positive racemase. But when you use the PIN4 cocktail that also includes high molecular weight keratin, it would be a clue that if you have high molecular weight keratin positivity of the nephrogenic adenoma, that it's less likely to be prostate cancer having aberrant high molecular weight keratin positivity in the lining epithelium. Something that looks a lot like nephrogenic adenoma is mesonephric remnants and mesonephric remnant hyperplasia. Probably you've seen a lot more of these in the GYN tract, for example, adjacent to the fallopian tube or something like that. But when you see these in or near the prostate, they can resemble prostate cancer because, again, it's a small gland lesion. If you use staining for basal cell markers, they're going to be lacking. There can be positivity for racemase. But again, just like nephrogenic adenoma, these would be taxate positive. And you might ask, well, what's the difference between one of these and a nephrogenic adenoma? Overall, there can be a lot of overlap. These lesions are often not immediately suburethral like a nephrogenic adenoma, so they're more within the prostate or can even be in the periprostatic tissue. So that is one difference. Here is an example. You can see the lobulated architecture of one of these. So you've got a cluster of glands, but fairly lobulated configuration. The secretions in the lumens often has a eosinophilic colloid-like appearance. There's a higher magnification. Nuclei are not very pleomorphic or atypical, generally lacking prominent nucleoli. This one has nuclear sort of bubbles, but doesn't have really good nucleoli. And here's packed state staining in one of these lesions. Here's another quiz case. Does anybody have a guess of what this lesion is that I'm showing here? Or maybe a clue is that it's actually not a lesion at all. So this is, oh, sorry. Sorry, what was that?
Are these seminiferous tubules or?
Oh, that's true. It does look a lot like it almost looks like epididymis or something like that. But actually what I'm showing you here is the central zone of the prostate. Mm-hmm. And so the central zone is the area that's mostly located at the base of the prostate, kind of in between the ejaculatory ducts and the urethra. It's kind of like a cone shape, and as you go towards the base, it becomes bigger, and as you go towards the apex, it sort of disappears. But something about the central zone that's kind of funny and that might be morphologically worrisome is that it often has this Roman bridging kind of appearance here, where in the breast or something like that, you might be worried about carcinoma in situ, but something to keep in mind is that this is totally normal in the central zone of the prostate. You have these Roman bridge type structures, the distribution of the nuclei is very haphazard, and sometimes the stroma is more dense, so it's more eosinophilic and dense than prostatic tissue in the peripheral zone of the prostate. So central zone often cancers are thought to not develop in the central zone. It's thought to be sort of a resistant area which doesn't have as much cancer, although I have seen PIN involving central zone tissue sometimes. Here's another case that I thought was exceptionally challenging on a needle biopsy. Here you can see this area at the edge of the biopsy. Zoom in, it looks like maybe poorly formed or fused glands, something like that. And perhaps the best clue that I'm leaving just barely in the edge of the image here is that you've got a ganglion cell over here. Does anybody have a guess what this is? So this is a paraganglion that was detected in prostatic needle biopsy tissue. So I think that can be also a worrisome mimic of prostate cancer, because as we know, prostate cancers are not very pleomorphic, and so a high-grade cancer like a 4+4 or 4+5 could look a lot like this. Here's the chromogranin staining in this particular case. So it stains very positively for chromogranin, just like, say, a pheochromocytoma would. Here's a PSA stain, which is essentially negative in this one. You might see a tiny blush here and there, but I think that reinforces the fact that you should always use markers both in favor of and against whatever diagnosis you're considering. So, if you did only PSA and you saw this tiny bit of blush here, you might say, I'm not sure, is that prostate cancer? But when you use markers both in favor of and against what you're considering, that can be a helpful clue. So paraganglion tissue can mimic a high-grade cancer in either a needle biopsy, or if you see it adjacent to a cancer in a radical prostatectomy specimen, it could mimic, say, extraprostatic extension. Another thing that can be worrisome histologically in the prostate is radiation atypia. So in general, the more ugly some prostate tissue looks in the setting of post-radiation, the more likely it is that it's benign. So prostate cancer glands that have treatment effect generally look even more bland than they do already. And the more pleomorphic ones usually are represent atypia of the basal cells. So here you can see in this particular one, let's zoom into the full screen. Here you can see in this one, there's some nuclei that are kind of big, irregular, hyperchromatic, but this is a benign gland with radiation effect. Here's another one. You've got some random nuclei that are pretty big, others that are medium, others that are smaller sizes. Here's another one over at the edge here that's got a lot of variation in nuclear size. But if you use immunohistochemistry, you can see that there's still a p63 positive basal cell layer in these glands with radiation atypia. And in fact, the basal cells are quite big, the ones that are picking up p63 here. But in contrast, cancer with treatment effect, the glands often become shriveled up and shrunken. Here's a cancer gland that's just a nucleus and kind of a ring of cytoplasm after treatment. Here's another one that has almost no nucleus. It's just basically a hole in the tissue with a thin rim of cytoplasm. And using the immunohistochemical staining here, you can see that nucleus is not a basal cell with p63, and there's a variable amount of racemase staining still preserved. So this is a cancer with a pretty impressive amount of treatment effect in the post-radiation setting, in contrast to the basal cell atypia of benign glands in post-radiation, which can look very big and hyperchromatic and weird looking. So moving on to urinary bladder. Any questions on prostate before I move on?
So Dr. Williamson, what would be your most important marker for nephrogenic adenoma? Because you say that many markers are overlapping between nephrogenic adenoma and prostate cancer, right?
Yeah, so PAX8 is really, I think, the best. You pretty consistently get PAX8 positivity in nephrogenic adenoma, and then the others can be sort of variable. So if I have a lesion, I'm pretty sure it's nephrogenic adenoma, but I just want to increase my confidence. I usually just use PAX8 alone.
And you roll up PAX2 as well?
Yeah, PAX2 is very good as well. In general, in our lab, we've mostly moved over to using PAX8 predominantly as a replacement for PAX2. We found it to be preferable. But in general, they both have very similar results. To my knowledge, most of the studies have found them to be quite similar.
Thank you.
Actually, I have a question. It's from one of the people watching on Facebook, and it's from Nima Tiwari, and she asks, they ask, how do you distinguish low-grade PIN in the central zone?
Yeah, so that's a great question. So in basically central zone, just by the nature of the way it looks, it can look a lot like PIN. And so I generally have a much higher threshold for considering something PIN in the central zone. So I really require it to have big nuclei, obvious PIN cytology, nuclear enlargement, elongation, pseudostratification, big nuclei. And so if it falls short of that, then I generally give it the benefit of the doubt and figure that it's just normal central zone tissue. And for the most part, I wouldn't worry about low-grade versus high-grade PIN. What we normally do is just to report if it meets criteria for high-grade PIN, then I use the diagnosis high-grade prostatic intraepithelial neoplasia (PIN). If it's something that that falls short of that, I don't even mention it if I don't think it reaches the level of high-grade PIN. Because interestingly, PIN, although it's thought to be sort of the presumptive precursor to prostate cancer, the rate of finding cancer on a repeat needle biopsy for a patient with PIN is not that different than the rate of finding cancer on a patient who had a totally benign first biopsy. And so luckily, even though we still try to report PIN, luckily the significance of PIN is pretty limited. And for the most part, urologists don't necessarily do any aggressive modification to what they're going to do based on diagnosis of PIN. So that's a great question. Central zone in and of itself looks a lot like PIN, or you might think it's PIN because of the funny haphazard organization of the nuclei and the bridging. But I hold it to a higher threshold, and in general, if you think something might be central zone, even sometimes I might mention in my report, benign prostatic tissue with central zone type glands or something like that, just to show that I looked at it. I could see if you were worried about it, but I think it's central zone.
Okay.
Any other questions?
Thank you. That's it for right now.
Thank you.
Dr. Williamson, regarding the nephrogenic adenoma, I'm just curious. So the etiology now is neoplastic process to the injury or just reactive?
I mean, so I guess the thought is, it's just kind of interesting, the way as I mentioned earlier about the implantation of the cells from the kidney. I guess the way I think of it is that probably it results from, the cells kind of implant and then they grow at this foreign site. So I guess you could think of it as sort of I guess it's kind of a hybrid. It's not quite maybe not quite a neoplasm. I'm not sure if anybody's done like a clonality or any kind of study to show whether it's truly neoplastic or not, or just kind of a proliferation, sort of an ectopic proliferation, I guess is a good way to think of it. So,
is there any malignant potential?
Well, that's a great question too. So, nephrogenic adenoma can overlap a lot in morphology with the entity clear cell adenocarcinoma, which you can have in the urethra, similar to what you can have in the GYN tract. So somewhat similar to clear cell adenocarcinoma of the ovary or uterus. You can have clear cell adenocarcinoma of the urinary tract. And one of the hypotheses for that is that does it potentially develop from nephrogenic adenoma? I think that's not really a favored hypothesis right now. Although they have morphologic overlap, I think most people believe that it doesn't develop from nephrogenic adenoma. It just looks similar. We've actually seen cases where patients have concurrent urothelial carcinoma and clear cell adenocarcinoma, and then the urothelial carcinoma will be positive for P63 and negative for PAX8, but the clear cell adenocarcinoma will show the opposite, PAX8 positive and P63 negative. So one hypothesis is that clear cell adenocarcinoma arises from kind of a pluripotent cell within urothelial carcinoma or something like that. Other hypotheses are that it could arise from some sort of GYN remnants somewhere in the urinary tract, like endometriosis or other remnants in the bladder wall. But at any rate, I think the most agreement is that there's really not thought to be any pre-malignant potential of nephrogenic adenoma, although it can look a lot like a clear cell adenocarcinoma, so something to keep in your differential diagnosis. But I think most people think that it's not exactly the precursor, it's just two lesions that have some overlap.
Got it. Thank you.
Moving on to the urinary bladder, and as I promised, I have a lot less material in the urinary bladder, although I hope not to do a disservice to it. Nephrogenic adenoma, again, in the urinary bladder, probably much more common in the bladder and other sites of the urinary tract, maybe the ureter. The papillary pattern of nephrogenic adenoma can mimic a papillary urothelial tumor. And so if you ever see a papillary tumor that has a cuboidal single cell layer, especially if there's sort of a hobnail look to it, I think that's a clue to hold back and be cautious that you're probably not dealing with a urothelial neoplasm. It's probably a nephrogenic adenoma anytime you see a monolayered cuboidal epithelium, although you can have denudation of a urothelial carcinoma. So if you see a lot of papillae and some of them are denuded and some of them are multi-layered, then that may just be denudation within a urothelial carcinoma. But a monolayered appearance would be strange for urothelial carcinoma. Again, PAX8 positive, and we talked about the variable staining with things like GATA3 and high molecular weight keratin. So here's an example of a nephrogenic adenoma in the urinary tract that's a nice papillary lesion. So So the urologist might even see that as a papillary tumor. But then when you see it microscopically, the clue is that it's a very nice cuboidal or sort of slightly columnar lining epithelium with a monolayered appearance. Again, it'll be Pax8 positive. Here's one that I thought was kind of interesting. It almost looks like a papillary RCC with foamy macrophages inside of some of the cores, but again, a very cuboidal to low columnar lining epithelium, fairly bland looking without the stratification of a urothelial carcinoma. Here's another one where you can see actually the surface of the urothelial mucosa is ulcerated. The glands are small and round. They're going down into the underlying tissue, and perhaps because of all of the inflammation that's associated here, there's a fairly impressive prominent nucleoli. And so kind of two of the patterns that you can have with nephrogenic adenoma, papillary and then tubular or glandular, like you can see here. Again, you could use Pax8 if you were worried about this one. This is one that I think is sort of tricky because the glands are very small and some of them almost look like a signet ring cell. That cell at the tip of the arrow actually has blue mucin in it and really looks a lot like a signet ring cell. But then here are other areas from the same case where you see the exceptionally nice basement membrane layer around the glands. These ones actually have pretty conspicuous nucleoli, so you might be worried on that basis. But when you see the thick basal layer, might prompt you to do a Pax8 and confirm that this is actually a nephrogenic adenoma. And this is, interestingly, a more recently recognized pattern. There was a nice study in Modern Pathology a couple of years ago which showed that you can actually have a flat surface lining epithelium that seems to be nephrogenic adenoma. And until recently, I think for the most part, we figured there were two patterns, papillary and tubular. But in this study, it was shown that you can often actually have also a flat lining. And so this is the same case. You can see that the surface, that entire surface lining is sort of cuboidal to low columnar and Pax8 positive, just like the few tubular structures that are down below. So again, that may not be a huge pitfall for any confusion with any kind of malignancy unless you're looking at those cells and thinking that that's a denuding pattern of bladder CIS or something like that, but just something that you can keep in the back of your mind, that you can sometimes have a flat cuboidal lining of the urinary tract, which is a flat variant of nephrogenic adenoma. Papillary or polypoid cystitis is another reactive process that forms kind of a papillary or polypoid growth. Some clues that you're dealing with this entity: the papillae are very broad, edematous or fibrotic, and they have a lot of inflammatory cells within them. Sometimes the clinical correlation can be very helpful. So if the clinical cystoscopic impression was of a reactive or inflammatory lesion, and you're thinking of a papillary tumor, it might be a clue to kind of hit the brakes for a minute, think about whether there's any possibility you could be looking at papillary or polypoid cystitis. Here's an example. Although the epithelium is making sort of broad papillary or polypoid projections, the lining is pretty bland looking. It's not really branching into smaller and smaller papillae like you might expect of a papillary tumor. Here's some more of the same case. Some chronic inflammation in the stroma. Yeah, here's another one. It's kind of hard to say exactly what part of it is von Brunn's nests that are just invaginating down versus some of it being papillary structures that are proliferating upward. In isolation, these few fibrovascular cores might look a lot like a papillary urothelial neoplasm, although this one, for example, is the tissue adjacent to a colovesical fistula. So when I saw this case, I thought that was a good reason to kind of pause and think about whether this could be, even though we've got a small proliferation of capillaries here, it looks like it's starting to make an early papillary tumor. Other areas in the same case are kind of just broad edematous humps with chronic inflammation and no significant atypia. And so in this case, I interpreted as most likely reactive to the colovesical fistula that was nearby. Pseudocarcinomatous hyperplasia is an interesting lesion that's been more recognized recently. And this is typically associated with prior radiation for prostate cancer. Almost all of the patients, about 3/4 of them, have a history of radiation for prostate cancer. And so a lot of it is probably radiation-related changes. The small subset that don't have that history, they often have some other kind of history, such as severe vascular disease or some sort of catheter in the urinary tract, sickle cell disease, something like that, that might explain why you could have ischemic changes to the bladder. But the microscopic appearance of this process is that you have a downward proliferation of epithelium that can mimic, an invasive carcinoma. However, a helpful clue is that there's a lot of fibrin around, and sometimes the epithelium seems to be sort of wrapping around the fibrin, like you can see here. And so anytime that I see vessels with a lot of fibrin, kind of a rim of fibrin around the wall, I always pause and think, does this patient have any history of radiation? Could this be pseudocarcinomatous hyperplasia? Here's another example. Maybe you can see it a little bit better. The epithelium kind of comes down here. It makes an angulated contour like you might think of as a cancer, but then it's wrapping around vessels with a big rim of fibrin in their wall. So anytime I see that, I pause and say, does this patient have any history of radiation, or do they have a history of prostate cancer? Even if you don't know that the patient has had radiation, if you see a history of prostate cancer, that can be a clue that most likely they have had radiation and you just weren't aware of it. Here's another example, that epithelium wrapping around vessels with fibrin in the wall. This kind of light pink fibrillary material contrasts to the bright red erythrocytes. Here's another example, big dilated vessels just under the epithelium with a lot of fibrin. And sometimes this holds true for both the prostate tissue and bladder tissue. If you see vessels like this that have very abnormal intimal lining, so you have this weird vacuolated, very damaged looking intimal lining, this can be a clue that the patient has had radiation. If you see these vessels somewhere else while you're looking around, either in a prostatectomy specimen or in a bladder specimen, see this severe vascular damage, it might be another reason to kind of scratch your head and say, wait a minute, has this patient had some sort of radiation? So some clues that you're dealing with pseudocarcinomatous hyperplasia. The depth is, again, limited. So it goes a little bit down and it has a pseudo-infiltrative appearance, but it doesn't invade to an indefinite depth. It stops at a superficial depth from the surface epithelium, and it does not extend to the muscularis propria. Atypia is generally limited, and sometimes the epithelium has a squamoid appearance, and then again, if you see that fibrin, that can be a helpful clue. Something that we've been very interested in recently in our research group, we presented an abstract at the USCAP meeting this year, is this pseudosarcomatous myofibroblastic proliferation of the urinary tract. So this entity goes by several names: pseudosarcomatous myofibroblastic proliferation, or if the patient has had some sort of previous procedure, you might hear the term postoperative spindle cell nodule, with the thinking that this is a reaction to some sort of injury or fibromyxoid pseudotumor. And it's not that this is an exuberant reactive process of some sort. Here's an example of one of these. You can see the muscular wall of the bladder down here in the lower right, and then this low-grade spindle cell proliferation occupying most of the field, which to me looks a lot like nodular fasciitis. And I've, in general, thought of it as very similar to the entity nodular fasciitis that you see in soft tissue. Here you can see some blood vessels and a low-grade spindle cell proliferation. Interestingly, these myofibroblastic proliferations in the urinary tract are often keratin positive. And so that's kind of a contrast to true soft tissue nodular fasciitis, which is generally keratin negative. And I have always speculated that maybe that has something to do with the origin of this lesion from an epithelial organ rather than true soft tissue. And you might think, well, if we're entertaining if we're looking at a spindle cell lesion, it's diffusely keratin positive, could this be a sarcomatoid carcinoma? And indeed, sarcomatoid carcinoma should probably be your number 1, 2, and 3 considerations anytime you're seeing a spindle cell lesion in the urinary tract. But I would argue if it's got this uniform, diffuse kind of thin strands of keratin positivity, that's actually kind of unusual for a sarcomatoid carcinoma. Usually with sarcomatoid carcinoma of the urinary tract, it's actually sort of difficult to prove that it's epithelial. If you have focal positivity for P63 or GATA3 or high molecular weight keratin, that's a helpful clue that you're dealing with a sarcomatoid carcinoma. But when I see this fairly uniform, delicate keratin pattern like this, I often think that that's more supportive of a pseudosarcomatous myofibroblastic proliferation rather than a sarcomatoid carcinoma. And here's the staining pattern for SMA, diffuse strong positivity, and you look really hard, you might even see a tram track pattern, which is sort of the buzzword for myofibroblastic cells, but they have two parallel lines of tram track cytoplasmic positivity on the SMA stain. Interestingly, this one had a lot of staining for desmin, which might raise the consideration of a smooth muscle tumor, although it was essentially negative for caldesmin, which is another very specific smooth muscle marker, or heavy H-caldesmin. So to me, I interpreted this as most in line with a pseudocarcinomatous myofibroblastic proliferation of the urinary tract. This one was ALK negative, so which to me would argue against the diagnosis of inflammatory myofibroblastic tumor, which can also occur in the urinary tract, although some studies have found conflicting results on whether those are true inflammatory myofibroblastic tumors at all. In one study from Dr. Hirsch's group, which is listed here at the bottom, many of the so-called IMPs of the urinary tract were actually ALK fish negative, even though they were immunohistochemically positive. In a study from Indiana group, many of them were fish positive in addition to ALK immunostaining positive. But at any rate, if I see negative ALK immunostaining, I generally consider that an argument against the diagnosis of inflammatory myofibroblastic tumor. And so the hypothesis that popped up to me about this entity is, well, it seems to me very similar to nodular fasciitis of soft tissue, and recently nodular fasciitis has been recognized to have a recurrent gene rearrangement involving the USP16. Do these also have that rearrangement? And for any of those of you that were at the USCAP meeting this year, we presented an abstract, one of our residents, showing that all of the cases that we've looked at have been negative for USP16 rearrangement. So it seems that these are molecularly different and probably not a helpful confirmatory tool to use that fish for the USP16. Although, please, if you have some cases, please feel free to test our hypothesis and prove us wrong. It would be great if there was a positive marker for this. I thought we were onto something, but it turns out they were all negative. Something that can be sort of a funny mimic is a crowded proliferation of von Brunn's nests. And interestingly, in the ureter and renal pelvis, for some reason, von Brunn's nests tend to be really crowded and small, like you can see in this picture here. So that can mimic a carcinoma. But again, maybe the number 2 tip of avoiding misdiagnoses in bladder and prostate is to look for the uniform depth. So a nested variant urothelial carcinoma is known for being, the buzzword deceptively bland, but deeply invasive. So these can go all the way to the muscularis propria, even though they look as bland as von Brunn's nests. But whenever you see a crowded proliferation of von Brunn's nests, especially in the ureter or upper urinary tract, they generally stop at a uniform depth. So here's the same case filling the whole screen. You can see these. Many of these are very small and kind of funny looking, but then if you go back to lower magnification, you can see actually there's a nice uniform depth where they all stop and they don't go any deeper than that. So that can be your clue when you're dealing with a crowded proliferation of von Brunn's nests. They maintain their respect for a certain line in the lamina propria beyond which they do not go. So I think I did okay on time. I just bled over a little bit. Sorry about that. But here we are at the end. In summary, we talked about earlier how you have a pretty high rate of diagnosing cancer in the urinary tract. And so hopefully some of these benign mimics have been helpful, things to keep in the back of your mind as things that may not be cancer in the prostate and urinary tracts. And always a helpful tip is that whenever you're making final decision about diagnosing cancer, to take one last look at it and say, is there anything else that this could be other than what I think it is? Always a good kind of hard stop to pause at that point and think about, is there anything else? And of course, if the clinical and histologic picture do not fit, like in the case of polypoid or papillary cystitis, where the clinical impression is the inflammatory process and you're thinking about diagnosing a papillary tumor. So again, thanks to all of you for the invitation to speak in this format today. I hope it was of some help, both to just general practice and also to those of you that are getting ready for the board exam sometime soon. I'd be happy to try to answer any more questions if there are any.
Thank you, Dr. Williamson. That was an excellent overview of benign mimickers and GU path, and without a doubt, a timely review for those of us preparing to take our pathology board soon. It looks like I have a question here from our Facebook audience. It comes from Naina Sadvani, and they ask which IHC marker is more sensitive for basal cell layer.
Well, that's good. That's a good question. Many, a number of markers have been used for the basal cell layer in the prostate, and probably the most common combinations. The current, a few years ago, the International Society of Urologic Pathology (ISUP) had a sort of a consensus meeting about IHC markers and made some recommendations. And the recommendation on that was that it's good to use some sort of cocktail that includes racemase, AMACR, in combination with either P63, high molecular weight keratin, or both. And so there was not a definitive recommendation that one is necessarily better than the other. What we do in our lab, you saw some of the pictures in my slideshow here showing the PIN2 cocktail. Often what I do is the 2 antibody cocktail that has racemase and P63. I do that on one slide. We have 2 unstained slides with every needle biopsy, and I often do that on one of the 2. And then on the other slide, I do a separate high molecular weight keratin stain, which has the advantage that you get 2 different views of the same lesion, so you'd get 2 different slides to look at. Although using just a basal cell marker like high molecular weight keratin or P63 by itself on a slide can be difficult because you don't have that positive feedback of also seeing the positive racemase. So overall, I really enjoy having some sort of cocktail that has a positive racemase and absence of basal cells with one or the other. We've played around a little bit with different high molecular weight keratins. So the PIN4 cocktail is called that because it has P63, AMACR, and then you might think of it as just 3, right? It's got the P63, high molecular weight keratin, and racemase. But the reason why it's called PIN4 is that actually the high molecular weight is CK5 and CK14. So that's why it's called the PIN4 cocktail. And those are the ones that are used in that combination. Whenever I do the high molecular weight by itself, it's the high molecular weight 34 beta E12 or K903. But I'm not sure that there's a clear winner, except that it's really great to have the dual color, to have a cocktail of some sort, even if it's single color, to have the positive and negative in the same slide, I think is a real advantage.
Okay, excellent. Looks like that covers our online questions. I think Rifan and Wei have a question for you.
Yeah, Wei, go ahead, please.
Sorry. So, hi. I have a question regarding the last entity about one brain's nests. So when you mentioned the death, which probably the regular architecture, how do you ever use the cytology atypia to differentiate it from the nest variant of urothelial carcinoma?
Yeah, so that can be helpful too. One thing that I've noticed with nest, even though it's known for being deceptively bland and not having a huge amount of cytologic atypia, sometimes it looks monotonous and has sort of a clonal appearance, so that it looks different than the adjacent benign. So like the surface looks fairly normal, and then you have this proliferation of small round nests in the lamina propria, and they all look identical to each other and different from the surface. That can be a helpful clue when the atypia is not that impressive. Some authors have written that the atypia often becomes more impressive when it gets deeper. So the deeper the invasive front, the atypia becomes more. So that can be another helpful clue. Unfortunately, there's no robust immunohistochemical markers that have been proven for this context to distinguish von Brunn's nests from nested variant urothelial carcinoma. I think there may have been some studies recently looking at molecular things like TERT promoter mutation status, but currently there's no great staining marker that you can do.
I see. Thank you very much, Dr. Williamson.
Thank you.
I have a question about just going about the terminology, going back to the pseudocarcinomatous myofibroblastic proliferation. Is that the preferred terminology over the postoperative spindle cell nodule?
I think either of them is okay, and in general, the postoperative spindle cell nodule may be more appropriate when you're dealing with a patient that's had a clear history of some kind of procedure, a biopsy or something like that, and then on their repeat cystoscopy they have a little bump or something like that, and it shows this myofibroblastic proliferation. In that case, then I think it would be fine to use the term postoperative spindle cell nodule. Or often when I report one of these, that a big mass that has occurred for unknown reasons. Sometimes I'll say in the comments, this is known by several names, including pseudocarcinomatous myofibroblastic proliferation or postoperative spindle cell nodule, kind of using them together. But in general, the postoperative spindle cell nodule is thought to be in response to some sort of injury, either a stone injury or having a previous biopsy or previous procedure of some sort.
And is inflammatory myofibroblastic tumor another synonym of these? Or, I mean, I know you mentioned that, but...
it's kind of confusing. The study from Dr. Hirsch's group showed that even the entities which were ALK positive, so what I do is if it's ALK positive, I would call it an inflammatory myofibroblastic tumor.
By IHC.
By IHC.
Right.
And if it's ALK negative, then I would sort of consider that an argument against being an inflammatory myofibroblastic tumor. Also, they often have I didn't include an image, but often they also have a substantial inflammatory component intermixed with the myofibroblastic cells. But yeah, to me, if it was ALK positive, I would call it that. Although I found it interesting that in Dr. Hirsch's study, they found that a good number of those that were even ALK IHC positive were FISH negative.
Right.
And her experience is that they all behave in a very benign way anyhow, so it may not matter that much which name you use. In the urinary tract in general, IMTs and in the pseudocarcinomatous myofibroblastic proliferations are benign. And IMTs, even though they're considered a kind of intermediate potential neoplasm and soft tissue, in the bladder they're mostly very good. So that the behavior is quite good with non-aggressive behavior. So it might be that actually most of the ones in the bladder are really more this entity than true IMTs.
Right.
But anyway, that's what I do. I use the ALK as the distinguishing factor, but acknowledging that some people consider them all the same entity. Some people, don't really consider them true IMTs, even if they're ALK positive and so forth. But that's what I do. If it's ALK positive, I consider it a IMT.
Okay. Rifat, do you have a question?
Yeah. I just want to keep in track with the same entity. So you said about smooth muscle actin positivity in this entity. So how often do you see it? And also you mentioned about tram track pattern of actin positivity. How much do you see? How often you see this pattern, the tram track pattern in IMT or pseudocarcinomatous?
I think both of them should be pretty consistently SMA positive, and the SMA staining should be pretty diffuse and pretty extensive because, being a myofibroblastic lesion, SMA should be very sensitive and, should be pretty diffuse and uniform. The tram track, pattern, I guess, is sort of in the eye of the beholder. I think I tried to include the photograph, which had a pretty diffuse staining, although it may not have had the best. See how good. Maybe a hint of the tram track, kind of, at least some of the cells here have a hint that there may be two or more parallel lines. So I'm not sure exactly of say, a incidence of seeing how often you see the tram track staining pattern. But SMA should be pretty diffuse and uniform and strong. And then other smooth muscle markers generally should be less extensive. If you have diffuse SMA, desmin, and caldesmin, then that would be an argument that maybe it's really a true smooth muscle tumor, such as leiomyoma or leiomyosarcoma. This one that I showed, I think, was interesting in that it had a fairly impressive amount of desmin, although the negative caldesmin I thought was interesting and sort of abnormal for it being, an argument against it being a full smooth muscle tumor.
Thank you, Dr. Williamson.
Okay. So it looks like we've covered all of our questions. Dr. Williamson, is there anything else you wanted to cover before we wrap up?
No, thanks very much for having me. I hope it was somewhat useful and helpful.
It's really helpful.
Absolutely.
Thank you so much, Dr.
Absolutely.
Williamson. Surely.
So great. Thank you, everyone. We appreciate you being here, and thanks again for joining Pathcast today, and we will see you next time.
Thanks a lot.